Hi everyone, welcome back. Today, let's talk about the treatment of heavy periods. Maybe worth you revisiting my videos about the menstrual cycle, where I discuss why periods happen and how, and the hormones, and secondly, why teens can get heavy periods. But let's dig into the treatment today. So, just to let you know, the light bulb moment that made me think I really have to help young people with heavy periods was this chair. I was seeing a young teenager, came to the clinic, and she literally walked with an absorbent pad to put on every chair she sat on. She wasn't even on a period at the moment, but just the fear of having such heavy bleeding and flooding made her take this pad everywhere. So here I am trying to help many young girls across the country, across the world, so that they're not put in this situation. There are many successful and effective treatments. In this video, I'm going to talk about weight and lifestyle. I'm also going to talk about the treatments that are available in turn for tweens and teens. And I'm going to talk about the treatment that often isn't offered to teenagers, although it is highly effective, the reasons why it's not offered, and what we do to get around that reason. So stay tuned for that bit. So, weight is really important and influences periods because the hormones around the menstrual cycle or the period hormones are what we call fat soluble. So that means that they dissolve in fatty tissue. So the more weight there is, then the more these hormones can dissolve in that tissue, and then that can interfere with the cycle, provide more estrogen, which thickens the lining more and make periods heavier. So if the tween or teen adolescent is overweight, then the first thing that can be really effective in reducing how heavy and in turn how painful periods are is to lose weight by regular exercise and diet. Basically, in terms of medical management, there are two routes that we can go along. There is the non-hormonal route, and then there's the hormonal route. And I'll talk about the non-hormonal route first. So there are certain benefits to the non-hormonal route in that the non-hormonal route, they do not affect the cycle. So if periods are regular and heavy, then it means that taking these medications that aren't hormones is not going to affect how frequently the periods come. So it's not going to affect the cycle because there are no hormones involved. The other big benefit, in my view, is that with the non-hormonal route, you only need to take the medication when you're on a period. So it means that there's kind of less of a commitment. And as we all know, teenagers are very busy these days and they may forget to take tablets, they may forget to take pills, and that will make the bleeding highly likely to make the bleeding erratic. So in that way, there is a benefit to avoiding the hormones because you only take them when you're on a period and then you can forget about them for the rest of the cycle. So the first one I'm going to talk about is called mefenamic acid, and that is a non-steroidal anti-inflammatory drug. So it is in the family of aspirin or ibuprofen or brufen, these drugs that we're all aware of. That's important to know because it means that if ibuprofen is already taken or brufen is already taken during the period, you can't take both of them. You have to choose one or the other. It is a painkiller, obviously, because it's an NSAID, but it also can reduce the flow. And it can reduce the flow of periods about 25 to 40% or so. So it can be quite effective. And it's really effective pain relief as well. It can be taken not only when bleeding is happening, so a lot of time the pain starts before the period actually starts, and the mefenamic acid can be taken even before the cycle starts and for the duration of the period. The dose is 500 milligrams 3 times a day. The second non-hormonal option is called tranexamic acid. So I guess maybe kind of a similar name, but it works differently. And the two can actually be taken together if necessary. Tranexamic acid is not a painkiller per se, but it is very effective and more effective than mefenamic acid in decreasing the flow of the period. How tranexamic acid works is that it's in a class of drugs called antifibrinolytic agents. And that means that it makes the blood a bit more clotty. So how I describe it is that if you imagine the period is at the beginning of the period, there's a waterfall of blood into the womb. That fills the womb with blood. The period hasn't started yet, but the blood is there and it's going to come out. What tranexamic acid does is, instead of a waterfall of blood, it converts it into a treacle fall. So the blood is a bit more sticky, it's a bit slower, so that it allows the vessels to be able to be sealed, etc., so that the amount of bleeding is less. Because it makes the blood a bit more clotty, a bit thicker, then it must be taken in caution in girls who have a history of blood clots in legs and lungs. In fact, we should probably be avoiding that circumstance, or a strong family history, or in someone who has a genetic predisposition to making clots, because we don't want to produce another problem. Tranexamic acid, why I give that story about the waterfall is that how much you take, which is 1 gram or 2 tablets 3 times a day, and that can be extended to 4 times a day if necessary. How much you take is important, like any medication, but with tranexamic acid, when you take it is absolutely critical. So because you're affecting the waterfall, if you wait to see if the period is heavy before you take tranexamic acid, it's not going to work because the waterfall has already happened, and that's the thing you're trying to influence. So what I say is, if you're taking tranexamic acid, as soon as you see any sign of the period, the first bit of blood, that's when you start taking it. And you take it for at least the first 4 days of the period, and by that time, the flow should be decreasing anyway. Sometimes this can be extended a bit more under medical supervision, but that's the standard dose and the standard duration. So that's a non-hormonal camp. The other side is the hormonal side, and these include oral progestogens. So a progestogen is a synthetic hormone that is similar to the female hormone progesterone. And if you saw my previous videos, you will know that progesterone has an important function of stabilizing the lining of the womb, putting the brakes on estrogen so that the lining doesn't get so thick. So what we do when we give it orally is that we're doing exactly the same thing, but not naturally, we're doing it medically. And what this does is it stabilizes the lining of the womb, and eventually, the longer you're given progestogens continuously, it thins the lining of the womb down. And as you know, the thinner the lining of the womb, the less there is to come away. The lighter the period, the shorter the period. So we give progestogens either cyclically to mirror a normal period cycle, or we can give it continuously, or we can give it for 3 months at a time. And it's variable depending on the girl, depending on what symptoms she's having, and of course her personal preference of how often she wants to have periods. The two commonly used ones are called noethisterone, and noethisterone has a significant estrogen-like activity. So we don't particularly like to leave girls on noethisterone for prolonged periods of time, particularly if they have risks in terms of blood clots, etc. And if they are, for example, contraindicated for them to go on the pill, because noethisterone is almost like putting you on the pill. So I used to use noethisterone a lot because it is really effective in controlling bleeding. So it's a good option to control an acute episode of heavy bleeding. Now, more frequently, I use the other one, which is called Provera, or medroxyprogesterone acetate. And that's usually a twice daily dose, which again, we can give in a cyclical manner. So for 21 days on, 7 days off, etc. That is more so if we're treating irregular periods, or we can give it longer term, maybe 3 months in a row, and then have a bit of a break, a 1 week off to allow withdrawal bleed, and then another 3 months in a row. They're very effective forms of management of heavy periods, very effective in regulating the cycle depending on how you give it, because it, basically by giving these drugs, we're telling the uterus how to behave and when to bleed and when not to bleed, etc. Side effects, well, all hormones have side effects, and some of the side effects are a bit of weight gain, sometimes acne, tend to be more prominent with norethisterone than the Provera, which is another reason that I prefer Provera. But in young, active teens, this is usually not that much of a problem. Before I go any further, I'll say that not every hormone works for every person, and sometimes we need to try one or two options, give a trial of one to see if that works well. If it works well, we continue it. If not, then we can choose another option. So moving along, the other options are all contraceptive as well. So that's an important issue to take into consideration when you speak to the adolescent, because if she is active, then she will need, well, I guess she will need contraception. So it's killing two birds with one stone. You provide reliable contraception as well as controlling the periods. The first one I talk about is the combined oral contraceptive pill. And these pills are what is usually referred to when we say the pill. And they contain estrogen and they contain progesterone. So they contain both hormones. I'm not a big fan of using the combined pill in girls within about a year of menarche or period starting, because they already have really high circulating levels of estrogen. And sometimes if we add more estrogen to it, that can result in issues that we weren't anticipating, unintended, unwanted consequences. So I tend to use progestogens that I spoke about before for girls within the first year of period starting, and then I'm a bit more relaxed about using the combined pill. So there are three basic ways you can take the combined pill. You can either take it cyclically, so like I mentioned before, one tablet a day, the same time every day for 21 days or 3 weeks in a row, and then stop for 7 days. And during that 7 day period, there will be a withdrawal bleed. Then restart for 21 days, stop for 7, etc. And it doesn't matter what you're guided for taking the pill. It's not whether she's bleeding or not bleeding. That doesn't matter. The only thing we're interested is in the days. 21 days on, 7 days off, etc. The next way is that we can take them in an extended manner, which in my experience, teenagers love this way, is that they can be taken for 3 months in a row. So again, one tablet every day for 3 months in a row, then stop for 7 days and then restart another 3 months. And when it's taken this way, instead of 12 periods a year, there are only 4 periods a year. And not only are there only 4 periods a year, but she gets to choose when she has the period, because we know when she has that 1 week break, that's when she's going to have the period. In terms of girls that can't have the pill, I mean, most girls can have the pill. In terms of girls that can't have the pill, again, girls who have a strong family or personal history of clotting, blood clots in the legs or the lungs, because the pill, because of the estrogen, puts you at slightly higher risk of that. Girls who have a demonstrated and diagnosed genetic predisposition to forming blood clots, and these are called thrombophilias. Girls who have an elevated body mass index, so above 34. So again, this is where weight loss can be useful, because if you're overweight, then the combined pill will not be an option for you, and losing weight can therefore put you in the category where it's safe to take the combined pill. The other big one is migraine headaches with aura. So a migraine headache with aura means that there is another symptom, a neurological symptom alongside the migraine that usually happens before the headache starts. And examples of these would be zigzag lines, visual disturbances. Those are the most frequent symptoms that you get with migraine with aura. Another way of giving combined hormonal contraception, like the combined pill, is the contraceptive patch or the Evra patch. And like the pill, it contains both estrogen and progestogen. But unlike the pill, it doesn't need to be taken every single day or applied every single day. The patch is changed once per week. So many adolescents do like the patch because there's less of a necessity to be that good about remembering to do something every day. Like the pill, it can be taken in various ways. So it can be used cyclically. So you change one patch a week, every week for 3 weeks, stop for a week, restart another 3 weeks on, 1 week off, etc. Alternatively, it can be tricycled like the pill. So change a patch once per week, every week for 3 months, then stop, have a patch-free week when a bleed will ensue, and then another 3 months on. Very effective, like the combined pill, but it just gives a bit of flexibility as to how the hormones can be delivered. Moving along, the next option, contraceptive, would be the progesterone-only pill. And sometimes this is called the mini pill because instead of the 2 hormones that are contained in the combined pill, this contains only 1 hormone. And again, it is a progestogen. That means it is a synthetic analog of the female hormone progesterone. Now, the progesterone-only pill is designed to be taken every single day without a break. And that means that you are delivering progesterone, the hormone that stabilizes the lining of the womb, in a consistent concentration, a consistent dose continuously. There is no break. The effect of this is that it thins the lining of the womb down, therefore less to come away, lighter periods, so that the longer that you're on the mini pill or the progesterone only pill, it means the lighter the periods become. And it also means that eventually, the longer on it, the more likely it is that periods stop altogether and you become amenorrheic, meaning that you have no periods. Now, when a gynecologist speaks about amenorrhea, we mean absolutely no bleeding ever. So although not everyone will have amenorrhea, most will have the occasional light flurry of bleeding, which is, absolutely most people can put up with, maybe a few months apart, a bit of spotting. So technically not amenorrhea, but functionally, it's as good as having no periods. So it's very effective. It is appropriate for those girls that I mentioned before who may have a bit of elevated weight, migraine headaches, contraindications. Those who have contraindications to the combined pill, many or most will be able to take the progesterone-only pill. Now, giving any hormone, initially, that may result in a bit of erratic bleeding, irregular bleeding. But I would encourage anyone, even if they're having some irregular bleeding, when they start taking it, to keep going, keep going, keep going. Because as you keep going, then that tends to settle and you get the benefit, the real benefit. So I always say, if you're choosing an option, unless it's horrendous, stick with it for a while to make sure, before you discard it. Because what we don't want to do is move on to a different option. If that doesn't work well, we don't want to have to revisit the first option because we didn't give it long enough. So my advice is to pick one, pick and stick with it for as long as you can, and hopefully you will derive the benefit. There's another option called Depo-Provera, which is a kind of longer term way of giving the medroxyprogesterone acetate, that's in the oral Provera that I mentioned initially with the progestogens. And this is an injection that is given 12 to 13 weeks apart. And it's given in a depot form, so you're given a fairly big dose, and that lasts you for that number of weeks before you need another one. It is viewed in adolescents as a second line because it can be associated with decreased mineralization of bone, and that means strengthening of bone. And that is an important function that's happening during puberty and adolescence. So the majority, about 90% of bone strength, is accumulated during adolescence. And after adolescence, in adulthood, there is very little bone strengthening. So that's the kind of the strongest your bones will be for the rest of your life. So as you can imagine, this is something we don't like to interfere with. And Depo-Provera can interfere with that. There is evidence that there's some catch-up bone growth, but for that reason, and because there are so many other useful options that can be effective, I almost never need to resort to Depo-Provera, but it is an option if necessary. Because you're giving a bigger dose, then there is a greater risk of weight gain and other side effects. Another option for delivering consistent levels of progestogen is the contraceptive implant or Nexplanon. This is a small rod that sits in the arm and it releases progestogen, which then thins the lining of the womb and often will make the periods lighter, or with continued use over a duration will essentially stop the periods or stop the periods. The life of the contraceptive implant is 3 years. As with all progestogens, there is a propensity for some erratic or irregular bleeding, and the implant probably has the greatest propensity to do that. So it is fairly frequently discontinued due to irregular bleeding. The last option, which I mentioned at the start of this video, is an option that isn't often offered to teenagers. And this is the Mirena coil. So the Mirena coil is a coil, a small pea-shaped device that sits in the cavity of the womb. And what it does, it is releases locally into the lining levonorgestrel, which is another progestogen. So they're all cousins. The norethistone, Provera, the desogestrel that's in the mini pill, the levonorgestrel that's in the Mirena coil. They're all progestogens, so they can all be, think of them as cousins. So they're similar in their activity, but it's not exactly the same hormone. But what this does is it releases this hormone into the lining of the womb exactly where it needs to work. Therefore, it's really effective in thinning the lining down, lightening periods, or causing amenorrhea or no periods in the longer term. As I say, it is often not discussed as an option in adolescents who have not been active in that regard. But I don't think it's an option that should be withheld for adolescents for this reason. So I offer it to adolescents, but the way I get around, because absolutely nobody wants that a girl's first experience would be an insertion of a coil. Absolutely nobody wants that. So when I offer the Mirena coil, and again, it's not usually first line. These girls have tried other things. They're still having heavy periods. They're still missing school. We need to find an option that works for them. When I offer the Mirena coil, I always offer to insert it under a general anesthetic. Therefore, they're not aware of the procedure, but they do get the benefits. The Mirena coil is really effective in controlling bleeding. Again, you must be aware, like all the other progestogens, that for the first 4 to 6 months while it's settling down, you can have some irregular bleeding. So what I say is roll with it. It tends not to be heavy, but frustrating. At worst case scenario, it can be every day. It's not usually that bad. Sometimes I have had girls that put the Mirena coil and they've not seen a drop of blood, from that point forward. And everyone will fall somewhere within that spectrum. But even if there is bleeding that's every day or almost every day, please stick with it, because after 4 to 6 months, hopefully it will kick in, and then you have the benefit for the Mirena coil for however long it lasts. It's recently been extended. Its lifespan for contraception has been extended to 8 years, so that's great news. And the benefit again is that they don't need to remember to take anything. It's plug and play. You put it in, don't need to remember anything, and it just works. Hopefully it doesn't work for everyone, but it works for most people. In my experience, everything I have discussed, many of these things, tranexamic acid, myarenical, everything I've discussed, in my experience, they're quite effective in adolescence, and we can we can pretty much always find a solution to the problem of heavy periods that are impacting significantly girls' lives. And actually, to the mums out there, you may have tried tranexamic acid, you may have tried some of these options and they're not worked for you. What I say about that is that, first of all, your daughter isn't you, so that how she responds is likely to be different to how you respond or responded. She's often at a different stage of life when you tried it. And actually, I think that most of these things work better. They're actually more effective in adolescents than adult women, because adolescents, there aren't the other things that cause heavy periods. So adults will often have either adenomyosis or fibroids or something else that can cause heavy periods as well. Whereas with adolescents, it tends just to be that the lining's too thick, things aren't quite cyclical the way they will be in the future, so that you're just dealing with that. It's like a temporizing measure until their reproductive system is fully mature and functioning as it should be, so that they have regular periods of reasonable flow. So as a result, the other thing to note is that she's unlikely to need to be on these drugs forever and indefinitely. It's just that stopgap between, when her periods deteriorate after they start until maybe 2 years down the line. So what I'll often say is, when we find something that she's stable on, we continue it for about 2 years. And usually the timing works, that we continue it until her GCSE exams, particularly if she's been missing school or can't study because they're so heavy or painful. And then we can stop and see what's going on. So and the other benefit to that is that sometimes there's some evidence that even being on the combined pill and even the low dose pill can again affect the formation of bone. Not that much, about 1% difference, but the effect is there. But in my mind, in medicine, we are always looking at benefit versus risks. And you're missing school, you're missing PE, you can't be on the swim team, you can't train because these periods are so heavy and so prolonged. Quite frankly, to me, it's a no-brainer. We need to deal with that because this is such an important time in a girl's life, educationally, socially, developmentally, mentally, etc., that we need to get on top of this. Thank you for listening. Please join my Facebook group, Gynecology Girl Talk, where we can have loads of discussion there of like-minded individuals. I will put the link in the description for this video. And of course, needless to say, please like, subscribe, because that helps to expand the audience so that I can reach more and more adolescents, more and more children throughout the country, throughout the world, and help them with their gynae issues. Thank you.